All right, this is not a philosophical talk, it is a clinical talk. And I was asked to talk about things that we can do every day to improve practice. So these are the kind of things I do. 10 ways to improve practice. First of all, how many of you here have heard about or done the Ferr's technique for dislocated shoulders? If I can have a show of hands. I don't see any hands, but it is dark there. Well, when you look at the anatomy of a shoulder, there are two muscles, the deltoid and the biceps, that are in spasm, and they hold the shoulder in the dislocated position. So this is not a new technique, but it's one we've been using for the past year in the department, the Ferr's technique. And look how simple it is. It reduces shoulders in about 3 minutes or 4 minutes compared to the typical methods that we use. So you have the arm extended and you just start wiggling it horizontally and while the patient is comfortable, and you keep going around and around until you finally reach marked external rotation. The shoulder pops in place, and then you can see that it's in place by crossing over his arm. So it's called the Ferr's technique. If you haven't used it, I would recommend that you try it. It really works well. When I do it, I sometimes have another person massage the biceps and the deltoid at the same time. If you've heard of the Cunningham technique from Australia, this is sort of a variant of that, but it's very successful. Next, what about lactated ringers versus normal saline? So there's been a lot in the academic news lately after a paper published in the New England Journal by the Vanderbilt group on the use of lactated ringers versus normal saline in hydration. I've asked, 5 or 6 residents about the osmolality, and nobody knows or nobody remembers that in fact lactated ringers is hypoosmolar to normal saline, and it's actually is hyponatremic and hypochloremic to normal saline. So the point about that is when we're giving fluids, we certainly should know a little bit about them. What the Vanderbilt study showed was that the increased chloride in normal saline will actually cause a hyperchloremic metabolic acidosis, renal vasoconstriction, and they showed rises in serum creatinine, which were totally reversible, but they showed those rises acutely when giving normal saline. But the point that nobody thinks about is that the effects of the volume you're giving depend on the amount of volume, the individual patient, and the underlying disease. We often wonder, can we give lactated ringers in somebody who's got an elevated potassium? Yes, you can, because the low potassium in lactated ringers, it's only 4, it really equilibrates with the high potassium. The thing to remember, if you think about lactated ringers, is you should avoid it in brain-injured patients. It is hypoosmotic. And in patients that have GI losses, gastroenteritis, vomiting, and diarrhea, really normal saline in the emergency department is probably still the fluid of choice. So the whole point is just think about what you're giving and why you're giving it. Don't reach automatically for lactated ringers or normal saline. There's old stuff in the literature that you cannot give lactated ringers with blood products because it's got calcium in it. That is a myth because the new methods of preparing packed blood cells are totally compatible with lactated ringers. We heard a great lecture on high-flow nasal cannula. Well, this was also one of my things we've been using this year. So this is a true case. This is a family member of mine who came in with severe fever, cough, myalgias, was extremely hypoxic. He could not tolerate BiPAP. He had been brought into a suburban small emergency department, and guess what? Because they had high flow oxygen available in the ED, They put him on the oxygen. His diagnosis was influenza pneumonia. And he, after 7 days of high flow nasal oxygen in the intensive care unit, he was progressively weaned off of it and went home without ever being intubated or ever on BiPAP. So it's really important. This is the way I think about it. If we're giving normal oxygen, we can't fill up the container well enough. As we see, this is a barrel that's half filled with water. So when you're using normal cannula oxygens or a non-rebreather bag, you're not filling anything up. And you're not giving enough to the patient. So the high flow nasal O2 does those two things. It fills up the container and it just delivers a high volume of oxygen to the patient. We've heard about a lot of uses, including Dr. Vanessa Cady's lecture when she uses it in palliative care. There was a question from the audience about somebody with an upper airway mass. That was a question in an earlier presentation. I had a patient like that with terminal laryngeal CA who came into the ED short of breath, would have been a very difficult intubation. We sat him up, put him on high flow nasal oxygen. His oxygenation remained stable. So that's another thing. With an upper airway emergency, you can switch to high flow nasal oxygen. So TXA is a wonder drug now. Aspirin was a wonder drug. It has many uses, and I'm sure you all use it every day. Here is some pathophysiology about it. Epsilon aminocaproic acid was what we used to use before switching to TXA, but TXA is much more potent. I often ask people, can you give this to pregnant women? Well, in fact, it is concentrated across the placenta and in breast milk. One of the things I always encourage my residents to ask about is pregnancy and lactation status in every female that you see in the ED. We know that we have to do pregnancy tests, but we don't often ask them if they're breastfeeding and are not now pregnant. So here's some data on TXA. How many use it for nosebleeds? Only a few hands up. It is fantastic in nosebleeds. If patients are on vitamin K, are on Coumadin, if they're on Plavix, or if they're on NOAX. And the way you do it is you take some of the TXA, soak it in gauzes, wrap the gauze around either your nasal, whatever you're using to pack the nose with, and put TXA in. You have to wait about a half hour, but it's very effective in nosebleeds, and you don't have to worry about its effect on patients with coronary artery disease or stents or valves or anything like that. About 6 months ago, I had a patient sent to the ED for a nosebleed by her ENT doctor because he couldn't stop it. And sure enough, she thought we were miracle workers because TXA stopped it. I also had a dentist send a patient to the ED for dental bleeding after extraction that could not be stopped with suturing or gauze. We soaked gauze with TXA, put pressure on. After 30 minutes, the bleeding stopped. So it has a lot of uses. I was surprised to find a recent meta-analysis where TXA did not appear to affect postpartum hemorrhage, which surprised me. I wouldn't hesitate to use it for that, though. Tourniquets. Tourniquets are back in vogue. For a long time, we were taught, no, 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 don't use a tourniquet. They're ineffective. They will hurt the vasculature, cause compartment syndrome. Not true. And this is a commercial tourniquet developed by the military called the CAT tourniquet, which I would just recommend you keep it in the ED. You put it on bare skin above the injury. It's best actually, you can put it on with the arm up if it's an arm injury. Make sure that you tighten the tourniquet to occlude venous occlude both venous and arterial flow. If you don't do that, you're going to have problems later on. And you can generally keep them on up to 4 hours, but you can apply them intermittently if you have someone with bleeding. Of course, direct compression is the best treatment of active bleeding. We've all been taught about tension pneumothorax. Where do you put the needle? Second intercostal space, midclavicular line. Probably not the right way. Military studies were done. They took CT scans on dead combatants and then put in needles in the standard places and found that usually using the midclavicular line, second intercostal space, you hardly ever got into the pleural cavity. The way they showed using CT scans on the same cadavers was to go at the anterior axillary line in the fourth intercostal space. You're not going to get anything bad, and it's going to be much more effective. Even in muscular military men, you still got into the pleural space. All right, another question. How many of you in adults have used Decadron or dexamethasone for asthma? Everybody down here are the ones who are using this stuff, so that's good. Well, 2 cases. I read about this stuff in the literature. There are many critics who say, oh, no, we don't have enough evidence to really use this widely. I had a 71-year-old woman who had just been treating with beta blocker drops for glaucoma, and she came in with her first asthma attack. She responded very well to 1 dose of albuterol. I'm like, this is a great candidate for Decadron. I gave her 12 of Decadron PO, gave her a second pill to take if she needed it in 48 hours. Her asthma never returned. So the studies in adults were on anyone with mild or moderate asthma might do as well with 1 or 2 doses of dexamethasone PO, 12 milligrams each dose, and they would be compliant with the medication. My husband has mild asthma. I'm like, okay, this is the real test of an ER doctor. He took his albuterol, and I'm like, okay, instead of all this prednisone, let's try Decadron. Fantastic. He had 1 dose at time 0 and another dose on the second day, and he was much better and liked my treatment. Now, I thought that was real evidence. So I would encourage you to use Decadron for mild or moderate asthma. The studies show there's so much non-compliance when you give the standard prednisone dosages over 5 to 7 days or whatever you decide, that this works a lot better. But remember, it's got to be mild and maybe moderate. Well, these were 2 cases of likely joint infections in young men. The first one is a patient who had a previous implant for a fractured radius who fell off a light pole during a hurricane in North Carolina and seemed to do okay, had 3 ED visits for a swollen wrist. Then, and he came into the ED, he indeed had a wrist diffusion. He had a low-grade fever. He was a young man. What do we think it was? About a month after that, I had a 19-year-old college student present to the ED because he had developed a knee effusion, had gone to student health 2 days before, had the knee tapped, but was not given any antibiotics. He then came in the ED when someone called him and said his culture was positive. So these are 2 young men. What was the diagnosis in a young man? Gonorrhea, of course, GC. And the thing is, both of these individuals, the first one, everyone was afraid to tap his wrist or didn't really think it was infection. In the student, they didn't want to treat him until they had culture results. Sometimes we get too dependent on labs and wait for cultures to be available. You may or may not have patient follow-up. Well, patient 1, his culture was eventually negative, and we gave him in the ED anyway, ceftriaxone, azithromycin, treating GC arthritis, the most likely diagnosis, and gave him vancomycin. He continued on ceftriaxone for 5 days, got well, went home. He was on the orthopedic service, so they're a bit more pragmatic in the way they treat joints. Patient number 2, who was the student, we knew right away he was called back because his culture was positive. He was admitted and was treated again for 5 days with GC. So again, in a young man, in an area that has an awful lot of gonorrhea, you need to think about that as your most likely choice. The first person, of course, got vancomycin in case he had MSSA or in case he had MRSA, but he did not have those. Nitroglycerin. We use IV nitroglycerin a lot now. Patients come in with acute chest pain. They're given nitroglycerin, 0.4 of a milligram. And this is another question I ask medical students and residents. Well, how many micrograms is that? I have yet to have anybody know. It's 400 micrograms. And this is one of the reasons why IV infusions for acute pulmonary edema or acute hypertensive crises, why we can easily go with 50 to 100 microgram per minute infusions. They're really not anything of a dose, even compared to what we're giving when we give sublingual nitroglycerin. So it's good to remember all of those dosages. And finally, the last one is epinephrine. And on this particular slide, I have images of the different ways that epinephrine is formulated. It's one of the real dangers in drug dosing in the ED that really nobody has paid attention to. We have a lot of other warnings about drug dosages, but not about epinephrine. The cardiac epinephrine is 1 to 10,000, and the reason it's in that dose is because you have to have it in a 1 to 10,000 dose to give it IV. When epinephrine comes in a vial, it can come in any concentration, so you have to be very, very careful about the dose you're giving. And you should, in every emergency department in which you work, go over the way that epinephrine is provided, learn the units, learn the concentration, so that you'll give the right dose. We took away all vials of nitroglycerin in our emergency department probably 20 years ago and went to the EpiPen. And the reason was we had 2 near deaths from giving the wrong dose of epinephrine out of a vial. One was a child who received what they thought they were given was 0.2 of a milligram of epinephrine, and in fact they gave him 2 milligrams of epinephrine. One was an ENT resident who came in with asthma and received a massive dose of epinephrine and developed a subendocardial infarction. That was enough for me. We took out we only have the cardiac epinephrine, and we only have the EpiPen, despite the pharmacologic issues about costs that are developing. There's a lot, and it is for this reason that there's a lot of controversy about the use of push dose pressors using epinephrine. If you use it, you have to use the cardiac concentration, which is 1 to 10,000, and it's 1 cc of the cardiac dose and 9 cc's of saline. If you give any more than that, you can have more problems. And again, you have to be careful about the conversion from micrograms to milligrams. So here's the 10 tips. Try the Ferris technique to reduce a shoulder. You will love it. I have reduced shoulders with just the pain dose of ketamine. If the patient is calm and relaxed, It's really, really easy. Think before you give lactated ringers or normal saline. Somebody's vomiting with diarrhea, give him normal saline. Get high-flow nasal oxygen in your ED. We don't use it every day, but we use it at least every week. TXA can stop bleeding in a whole lot of places. Keep a tourniquet in your car so that you can use it. Switch to putting the needle in the fourth intercostal space in the anterior axillary line for tension pneumothorax. Try 12 milligrams of Decadron for mild asthma. Think about gonorrhea and gonococcal arthritis in a young person with a joint effusion. Give a better dose of IV nitroglycerin. Don't be afraid of 50 to 100 micrograms per minute. And finally, be very, very careful and learn about the dosing of epinephrine that you have in your ED. I hope those tips have helped you. I will say they sure have helped me. These are all in this past year that I've been doing this. Thank you.